Today we're going to begin the first of a three-part series on psychological therapies, and we're going to start with Module 52. So, the history of mental health treatment has a long and sordid past. Historically, when people displayed unusual behaviors, they were either locked away in insane asylums or prisons, or they were treated using very old-fashioned ideas of what mental illness were. Many people thought that people who displayed symptoms of mental illness were possessed by evil spirits, as we previously discussed, and they would either beat them out of them, bleed them out, or they would let the spirits out through holes drilled in the skull, as you can see on the right. So very effective ways of handling mental illness, as you can imagine, and obviously I'm being sarcastic. However, there were reforms in mental health treatment when they realized that this type of treatment was barbaric. This type of chair described below is seen to be an improvement in medical treatment. It was meant to have a calming effect on those with mania. So you can imagine somebody who's in the throes of a manic episode now being placed in a chair like this. You can imagine that would be very calming. Again, I emphasize my sarcasm there. Other reforms in treatment went from viewing the insane as being ill instead of being possessed, which actually was a huge step forward, treating them with tenderness instead of harshness, housing them in hospitals rather than locking them up in asylums, and developing psychotherapeutic treatments, medications, and community support to allow life outside of hospitals. It's really only in the last 200 years or so that we've seen any movement in this direction. Previously, people who had mental illness were very much mishandled. So currently our treatment for mental health problems has two main facets. There's psychotherapy, which is what we know as talk therapy, an interactive experience with a trained professional working on understanding and changing behavior, thinking, relationships, and emotions. There's also biomedical therapy, which is the use of medications or other procedures like electrical shock or magnets to reduce the symptoms of mental disorder by directly affecting the body and changing the brain chemistry or the electrons, things like that. There are also many people have both. They have psychotherapy and medication therapy. So when we combine multiple types of psychotherapy, we're going to learn about the different schools. People are said to be eclectic. This is, you fit the client's problem, strengths, and preferences. My theoretical orientation is CBT, and I'd actually argue that eclecticism is not necessarily the way to go, because it's important to have a theoretical orientation which is similar to kind of your worldview, and therefore you apply techniques that make sense in that worldview. But as I mentioned, medication and therapy can be used together, and many times it can attenuate the goals. So the main schools of psychotherapy, and there are many of them, but these are the main ones that you'll probably hear about, are psychoanalysis, which is psychodynamic therapy, which is based on Freud. Humanistic, which is client-centered therapy, which is focused on the work of, his name eludes me right now, I can see his face. We'll get back to that, and I'm sure it will come to me. Behaviorism, which is using conditioning based on the work of Watson, and cognitive therapy, which is changing thoughts, which is based on the work of Aaron Beck. Most people today are cognitive behavioral, which they incorporate both cognitive and behavioral therapies. Carl Rogers, that was the name I was trying to come up with. So let's start out with psychoanalysis. Psychoanalysis refers to a set of techniques for releasing the tension of repression and resolving unconscious inner conflicts. So basically the goals of psychoanalysis is to make the unconscious conscious. And so Freud postulated that much of mental illness is caused by these repressed feelings, and so you kind of have to make these repressed feelings in the unconscious kind of more on a conscious level. So he used techniques like free association, where the patient speaks freely about memories, dreams, and feelings, and interpretation, where the therapist then suggests unconscious meanings and underlying wishes to help the client gain insight and release tension. So this is, you can see below, this is what Freud's a therapy room looked like, and people would lie down on the couch, and Freud would kind of sit at the head. He wouldn't look at them, and he would listen to what the patient had to say. For psychoanalysis generally would be every day for many, many years at a time. And even today, when I see patients in private practice, there's still kind of the feeling that one should be lying down on a sofa, and I've had patients who've actually done that. So interpretation in psychoanalysis is where, as I mentioned, the therapist sees unconscious meaning in resistance, dreams, and transference. So the resistance is when the therapist notices times when the patient seems blocked in speaking about certain subjects. And so that's when the patient has a hard time talking about something, which is generally emotionally charged. And so the therapist will then make interpretations there. The therapist also interprets dreams, kind of the meaning behind our dreams, because it's viewed as that being some sort of an expression of our unconscious thoughts. And then transference is when the patient has reactions towards the therapist that are actually based on feelings towards somebody else in the past, and then the therapist interprets those for the patient. So more modern day psychoanalysts actually have moved into the direction of interpersonal therapy. That while psychoanalysis is still practiced in certain circles, generally people have moved away from traditional psychoanalysis and are using either brief psychodynamic theory or interpersonal theory. So if we kind of do a comparison, a comparison here of the two of these. So psychodynamic therapy is a less intensive version of psychoanalysis. It's fewer sessions per week and fewer years, and it's less about sex, it and superego, but it's more focused on getting kind of self-aware and insight into the unconscious thoughts. And the therapist also suggests changes in thinking patterns and relating to other people. So psychodynamic therapy is the more modern view of psychoanalysis, but it's rooted in many of the same things. And as you see, while it's not every day, it's still multiple times a week and for many years. Interpersonal therapy is a further extension of psychoanalysis, and the goal is less focused on insight and more on relationship and behavior change and symptom relief. In interpersonal therapy, the patient is seen to be ill and takes on the sick role, and therefore they kind of allow themselves to take it easy, and therefore you work on kind of resolving some of the grief associated with loss of relationships. And this could be loss of a job, loss of a loved one, loss of a home, and how to handle some of those things using coping skills. So the humanistic therapies were developed by Abraham Maslow, who had the hierarchy of needs, and Carl Rogers, who is the one that talked about unconditional positive self-regard. And it really emphasizes the human potential for growth, self-actualization, and personal fulfillment. So it's a more positive view of psychotherapy. So humanistic therapy attempts to support personal growth by helping people gain self-awareness and self-acceptance, whereas client-centered therapy is Carl Rogers' name for his style of humanistic therapy, whereby you kind of reflect what the patient is saying, you constantly give them support. So just to kind of compare humanistic versus psychoanalytic theory, the goals of humanistic is to promote growth versus curing mental illness. You take responsibility in humanistic therapy for your own feelings and actions, whereas in psychoanalysis you want to bring the unconscious into conscious. The therapist in humanistic therapy provides an environment in which growth can occur, and in psychoanalysis, the therapist provides interpretations. The content of the therapy in humanistic therapy is focused on conscious feelings, the actual self and the ideal self, and kind of the incongruity between there and how to reach the ideal self. Whereas in psychoanalysis, it's the unconscious conflict. And the humanistic therapy is focused on the present, the future, whereas psychoanalysis is focused on the past. So a part of Rogers' client-centered therapy is being non-directive. So you have the client kind of come up with the insight and the goals rather than dictating interpretations to the client. You're genuine, so you're yourself and you're truthful, and you don't put on a therapist facade. You kind of react to the client and share your feelings and thoughts and emotions. You're accepting and show unconditional positive self-regard, and so you teach the client to accept themselves despite any weaknesses, so they learn to love themselves, and you model this for them. And you're empathetic, so you want to demonstrate careful attention to the client's feelings by reflecting what you hear the client saying. So it's kind of like the client says something and then you summarize it in a capsule summary. So the client is saying, I'm having a lot of trouble with my husband and this is going on, and this week I had a lot of fights. And so you reflect back and you can say, it sounds like you had a really difficult week this week, to show that the client that you really heard and that you're understanding. So you're summarizing. So, so your father wasn't around much. You invite clarification and elaboration. So you say, when you're saying anxiety, what does that feel like to you? What's going on in your body and your thoughts? And you reflect feelings. It seems like you're disappointed, am I right? And those are techniques that any good therapist would use. I mean, you also have to do, generally in CBT, cognitive behavioral therapy, which is what I practice, we also, talk about different techniques and teach people different techniques, but we use a lot of these techniques as well as informing part of the relationship. So behavior therapy is kind of the more stuff that's based on Watson and Pavlov's work. And so people have speculated that insight is not sometimes helpful to recover from some mental problems. And the client might know the right changes to make, but find it hard to do it. So behavior therapy uses the principles of learning, especially operant and conditional learning that we've talked about before, classical conditioning, sorry, to help reduce unwanted responses. And we can do this for things such as addictions, emotions, things like that. So counter conditioning refers to linking new positive responses to previously aversive stimuli. So if you've been conditioned to fear stores because you've had panic attacks there, you have to be led into a store and then help to do relaxation exercises. And so now you can go in the store without experiencing panic. And so now the store is related with relaxation instead of fear. So exposure therapy is something that we use for a lot of our anxiety-related thoughts and feelings. So for example, phobias. One of the things that we do when we're afraid of something is we stay away from it. By doing that, we actually make the situation worse. By doing exposure therapy, where we expose ourselves to our fear, we kind of realize that, you know, nothing super bad generally is going to happen, and our anxiety to that fear decreases. So if you've ever seen the show Fear Factor, where people kind of stay in things with spiders, initially they put them in with spiders and it's like horrific, but then the longer you stay there, the more your anxiety is going to drop. So what mistake is Professor Gallagher making here? So Professor Gallagher and his controversial technique of simultaneously confronting the fear of heights, snakes, and into the dark. So that's just too much for one person to handle. So what you would do is, for some people, they want to do exposure or flooding, which is when you do it all at once, like was shown in the cartoon here. But generally, people work better with systematic desensitization, whereby you gradually expose them to their feared stimulus. So if you're afraid of a spider, you may not flood them by putting them in a cage with lots of spiders, but rather you would have a spider, you would have them watch a drawing of a spider, a video of a spider, you would have them be in the same room as a spider, and then gradually work to having them have the spider in their hand. But this would be over a period of several sessions. There are different versions of exposure therapy. Sometimes it's impractical or it's not possible to do it. So people who have fear of flights often use flight simulators to simulate it. We've also done this now with PTSD, as we used exposure-based techniques to treat post-traumatic stress, where you have them wearing, you know, these glasses that you see on the left, and you can expose them to these video simulations that are very much real in battle and combat. You can have them exposed to those situations. So this is called virtual reality therapy, and you can do it for social phobias as well. This is another good example, a bedwetting alarm. I most recently used this with my daughter. She was having difficulty wetting the bed at night, but she wouldn't wake up, and so we used this device whereby you place a monitor in the underpants, and it detects wetness, and then it goes off and it wakens the kid, or if it doesn't waken the kid, it awakens you, and you have to go and wake the kid up. And after about a week of this, the body starts to be more aware of the sensations, and therefore decreases the bedwetting behavior. And so this isn't necessarily operant conditioning, but it's kind of a form of conditioning. And so the association is being made between the biological state, a full and relaxed bladder, and the sudden alarm sounding. And it kind of resembles classical conditioning. We also use aversive conditioning. So with drugs, for example, they have a medication that you can take. Again, the name eludes me, so you forgive me. If people have a substance use problem, like if they drink alcohol, antabuse. If people have an alcohol problem, they can take this medication called antabuse, and then if they drink alcohol, it's going to make them nauseous, such that alcohol then becomes aversive. Although what I've found is that this isn't necessarily the best cure, because while it may decrease it, people still will drink through the nausea if they have a serious addiction. It can be helpful along with many other techniques. Operant conditioning therapy refers to the shaping of chosen behavior in response to the consequences. So in behavior modification, you shape the client's chosen behavior to look more like a desired behavior by making sure that desired behaviors are rewarded and problematic behaviors are unrewarded or punished. And so you can see, those of you who are parents, this is basically what we do. Applied behavior analysis is used with nonverbal kids with autism. It rewards behaviors such as sitting with someone or making eye contact, and then you don't reward off kind of topic behaviors, or you can sometimes give them punishments, although that's not usually used. You can also then institute token economies where you use token stars or other kinds of things that symbolize the rewards, and then a greater reward is given at the end. So this is used oftentimes with children. For example, like my daughter had a chore chart, and every day she did a chore, she got a sticker, and at the end of the week, if she had 5 stickers, then she would get a larger prize, or like her allowance. So there are a lot of people that critique behavior therapy. When does it work? Do the changes stick? How to hold new behaviors in place? What we do know is that it often works, but sometimes things come back spontaneously. For example, my daughter, while she had been dry for almost a year, suddenly this fall when she switched into grade 1 started wetting the bed again. But then we reinstituted the alarm, and within a few days she'd stopped wetting the bed again. Sometimes just changes in routine can lead to the behavior re-emerging. So to ensure maintenance of change, a transition is needed from artificial reward to awareness of natural environmental consequences. So obviously kids are not going to get rewarded with tokens for everything they do in life, and so there have to be other rewards, more intrinsic rewards. Some people question its ethicality. So since conditioning operates below conscious awareness, couldn't people's choices and reactions be manipulated without their consent? And so in order to minimize ethical problems, we would get the consent of the guardians, especially with kids. Obviously, in many cases, they can't give consent, and so the guardians would give consent. And that you could develop goals for treatment that are humane than the alternative. For example, shaping autistic behavior is better than institutionalization. So moving on to cognitive therapies, these are therapies that will go on to change our thoughts. And so oftentimes you probably know that people who have depression often have very negative thoughts. So you can have, in the example below, the same situation, the person lost a job. In one case, the person has the belief that I'm worthless, it's hopeless, and they feel depressed. In the other situation, the person thinks, my boss is a jerk, I deserve something better, and they're not depressed. And so you can see that the same event happened, but because people have different thoughts, you can have different outcomes. So cognitive therapy really works to alter these negative thoughts and works with the client to identify them and challenge those negative thoughts. So there are 2 schools of cognitive therapy. There's Albert Ellis, who is based here in New York City and passed away a few years ago, and he did what was called rational emotive behavior therapy. He's kind of a fun guy to watch. There are lots of YouTube videos of his therapy, so if you're interested, you can Google Albert Ellis and watch that. And Aaron Beck was my postdoctoral mentor. He's still living. He's in Philadelphia. He works at the University of Pennsylvania, and he developed cognitive therapy for depression, which is focusing on cognitive distortions. So basically, at the same time, both Albert Ellis and Aaron Beck individually came up with cognitive therapy. They named it something slightly different, but both kind of moved forward in the field. Donald Meichenbaum kind of expanded on it by doing stress inoculation therapy. He used practicing healthier thinking before facing a stress or disappointment or frustration. So according to Aaron Beck, he helped people see how depression was worsened by errors in thinking such as catastrophizing. So now that I've made a mistake in my lecture, I failed as a professor, students can't take me seriously and they can't learn from me. Hopefully I don't think like that, because I would then give up teaching, because I make mistakes all the time, as you've noticed, and I stumble over my words. So I have learned to be gentle on myself and know that most people do stumble and we have to keep on going. So Beck's style of therapy helps clients notice and change these errors in thinking. So cognitive behavioral therapy is an interface between both cognitions and behaviors, and we find that this is the most effective in working with people. So for example, using cognitive behavior therapy, people with OCD, we teach them to resist the urge to act on their compulsions, as well as to manage their obsessional thinking, and so we do a 2-pronged approach. Other types of therapy are family therapies, where we work with families as a system, because oftentimes when one person is in distress, the entire family is in distress. There's also couples therapy for people who are having marital problems. Group therapy is done when people have similar types of problems. We use that oftentimes with offending populations. It's more cost effective and you can get support. These are kind of like self-help groups in many times. And self-help groups are slightly different than group therapy in that they're often led by peers. And they're really there to provide social support and kind of make people feel more normal with their behaviors.